Okay, guys, welcome back. We're going to get into lower airway diseases, specifically these ones that are listed on your screen. And we're going to tear down each one of these one by one, kind of giving you guys a brief overview of what you guys might see as far as a description of it, the actual pathophysiology of it, some of the actual signs and symptoms that you guys are going to see, and specific management that may come up with these disease processes. Okay, so pleurisy in a nutshell is the actual inflammation of the pleura, the actual pleura sac that kind of covers our lungs, and it creates a friction rub. And really, what it is due to the inflammation. It's almost as if we are drying out the actual lining of the lungs, and we could also be messing with the fact that we could be, because of the inflammation, we can be blocking that area of surfactant, right? Or whatever kind of lubrication that we're using in order to keep our lungs from rubbing on the inside of our chest wall. It doesn't sound pleasant, right? It causes the friction rub. And it's really just the layers of the pleura that are actually rubbing together. This is usually not just by itself, okay, guys? I don't know if I've ever heard of somebody that just had pleurisy. This is usually also because of some other. This could usually as a symptom associated with some other kind of respiratory disease process, and it can really be anything, guys. Right? Anybody can really get pleurisy if they have a history of any kind of respiratory disease process, such as like a COPD or some kind of CHF or something like that. However, most of the time, from my understanding, these are usually found with people that also have some kind of pneumonia going on, or some kind of emphysema patients due to that chronic abuse of toxins. They could develop this actual disease, the symptom of a disease process. So how do we usually see this presentation when it comes to our patients? It's usually the only way that we're truly going to be able to see this is when somebody is actually going to be complaining of pain when they're breathing in or possibly breathing out, or pain that they're not able to expand their chest in order to take that big deep breath that they're so needing. And then we listen to lung sounds, and we can actually hear the actual friction rub of the pleura of the lung. Okay, but again, it's going to be that sharp, sudden, intermittent chest pain with related shortness of breath. Okay. A lot of the times when we're dealing with patients with pleurisy, depending on which side the actual disease process is on, specifically if we're dealing with like a pneumonia, let's say, I'll give you an example of a pneumonia. Let's say this patient has a pneumonia somewhere in one of their right lobes, or multiple lobes of their right lung. They're going to complain of that referred pain also to the associated shoulder, right? So if they're complaining of that shortness of breath, they might have a little bit of a fever, they might have this kind of productive cough, and they say that they really can't get that full sensation of taking a deep breath in because of the pain. And they're also talking about referred pain to the shoulder as well. More than likely, we're probably dealing with a pleurisy. But really, the only way for us to quote unquote diagnose it in the field is if we hear it. And again, the people that I have mostly heard this in is the COPD patients and pneumonia patients. And it can be, from my understanding, they can be audible, where you don't even need a stethoscope to hear it. It can be so bad, or so much of the actual pleura of the lung is actually rubbing together. When we're talking about the actual, let me change slides here real quick. Let me get to the next slide, guys, sorry. So because we are actually having that fluid buildup in the actual pleural space, we can develop that pleural effusion, okay? Or that's really what the definition of the pleural effusion is the fluid collecting in the actual pleural space. If this keeps rubbing up and rubbing up against the actual pleuras or the inside of the actual chest wall, we're going to cause some significant damage to that tissue. Remember that your lung tissue is extremely fragile. It does not like to be disturbed whatsoever. And because of that, if it keeps rubbing and rubbing and rubbing, rubbing up against that lung, we can actually develop a hole. We can also develop a pneumothorax at that point. We can hear signs of agophony. Hopefully you guys remember what that is, because I'm not going to go over that again. And if it's very large, usually these have to be drained of their fluid in order to kind of help out the patient. I've never seen a pleural effusion actually go to a collapsed lung, but from my understanding that these can be so large that when you guys actually, if you need to, go to dart the chest, you can actually see plasma coming out of the end of the actual tubing of the chest dart. And if you guys see that, it's basically going to be the exact same thing that you guys would do if you would have seen blood coming out of that chest tube, which was just, or that needle decompression. And all that would be is just pulling out that chest dart and covering up the hole and try to equalize the pressure of your patient. But these patients do need to go to the hospital. And really, when it comes down to it, there's really not much that we can do in order to help these patients out. So again, remember that pleurisy is usually associated with some other kind of disease pattern, right? So when it comes to management, we're going to manage that disease pattern in order to try to help out the pleurisy. But really, when it comes down to it, we're just going to be mostly supportive. We're going to provide comfort care. This could possibly be a candidate for maybe a little bit of pain meds to try to help that out a little bit. But really, we just need to supportive care and get them to the hospital so they can start some antibiotic or antiviral, whatever it is they're dealing with, some therapy in order to try to help them out. Okay, so moving into lower airway problem, cystic fibrosis. Basically, this is begins usually in infant years of our patients. It really affects the digestive and the respiratory systems, and specifically because their mucus is much thicker than a quote-unquote normal person, all right? The actual chloride concentration in their mucus affects the water concentration in their mucus, and that's why it's an actual mutation, and that's why their mucus is much thicker. But this is actually an inherited disease. It's a metabolic disease of the sweat glands and our exocrine glands as well. So this is a autosomal recessive gene, and remember that that's just basically a trait or disorder, or unfortunately sometimes a disease that can be passed down through families. And the weird thing with cystic fibrosis is that both parents have to be carriers in order for somebody to have cystic fibrosis. It's more common in Caucasians, about 1 in every 2,000. Our African American friends, about 1 to 17,000. And in Asians, it's actually extremely rare. So it's mostly found in our white friends and our black friends as well when we're dealing with patients with cystic fibrosis. So because we are actually having the electrolyte shift of chloride with the water in the body, which actually produces the thick mucus, we can also have a lot of sodium chloride be lost due to their profuse sweating. That is usually also a common symptom associated with cystic fibrosis due to their kind of overactive sweat glands. But when we're talking about GI stuff, it usually can obstruct the pancreas, the intestinal glands, and the actual bile ducts of the patient. Most of these people do have some kind of GI feeding tube in order to get them the nutrients that they need. And then we can develop some serious mucus plugs in the lungs that can harden around the actual alveoli sacs. And obviously, if that happens, we're not able to expand and contract those alveoli sacs. So we are dealing with some serious respiration issues for the gas exchange at the alveoli level. So when we're dealing with the actual recognition of cystic fibrosis, really it's going to come down to the history. Most of these people are going to have some type of caretaker, whether it be actual family or a employed caretaker in order to help take care of them. History of airway obstructions, okay, specifically chronic coughs. They could have, more than likely, they are oxygen dependent. They could have recurrent respiratory infections, specifically like could be pneumonias, depending on how bad their actual mucus plugs are. Bronchitis. It can actually almost present as a left-sided congestive heart failure in some of our patients as well. Very, very diffuse wheezing, and that's because we have all that all that thick mucus buildup within our lungs. It's actually kind of constricting our bronchioles, leading up to the bronchi. They can have frequent foul-smelling stools, salty taste on their skin. Please don't be going out there and licking your patient's skin to diagnose cystic fibrosis. That's kind of gross. And they can't stand hot environments. Okay, they are very intolerant to temperature changes and variances and stuff like that as well. So we need to make sure that we're putting these patients in a position of comfort. We need to try to make sure that we're doing comfort care. Try to get the back of the ambulance to a temperature that they can handle. We want to provide or continue their oxygen therapy. We want to make sure that we definitely are ready to suction. And if the patient is still alert enough, they can suction themselves. Or have the ability to suction themselves, they can do that for you, so you have a free set of hands. Nebulized beta agonists, yes and no, I guess. They may not be very helpful, but worth attempting, right? Specifically with the albuterol, right? But the problem is that we're dealing with the mucus, and that's what's causing the actual wheezing, and it's a mucus that's kind of dealing with that electrolyte imbalance between the chloride and the water and the sodium itself. So yeah, you can attempt it as long as there's no contraindications. Could be very beneficial to our patients for doing that. We can try assisted ventilation. Me personally, I love CPAP on these patients, giving them just a little bit of PEEP and kind of working your way up, making sure that we're still monitoring the end tidal and the oxygen saturation as well. But I think CPAP goes a long way for these folks if they're able to tolerate it, and we don't have any contraindications for the CPAP to begin with. Okay, so still in the lower airway, we're going to talk about the actual possibility of neoplasms of the lung. And again, a neoplasm is just an abnormal growth, right? So basically like a benign or possibly a malignant tumor. There's about 150,000 new cases a year. Usually occurs between the ages of 55 to 65, and most of these people, unfortunately, are going to die within that year. 20% of them usually actually have a local, only found locally in the lungs. 25% can actually spread to the lymphatic system, and obviously with any cancer, once it kind of spreads to the lymphatic system, it could be very detrimental to our patients, kind of leading into that metastatic cancer where they have cancerous tumors from really head to toe when it comes down to it. And about 55% of the 25 that spread to the lymphatic system will develop into a metastatic cancer. Prevention for neoplasms is really kind of making sure that we are not either voluntarily or involuntarily inhaling toxins, right? So smoking, of course, we all know smoking is terrible for you. This increases your chances of lung cancer quite a bit. And then we have environmental hazards, such as like asbestos in our old buildings. Asbestos was used to insulate old buildings, and it's extremely toxic to us, specifically if we inhale it. But some other things to think about is like some of our welders. people that do welding, inhaling those toxic fumes, if they're not doing this in a kind of well regulated airflow space, they too can also develop neoplasms. Common presentation for these patients is usually some kind of respiratory difficulty, which will quickly lead to distress. And because of this, it's usually because of their cough. They kind of could have that dry smoker's hack, that hoarseness in their voice, or even possible voice changes altogether. But these guys can go into coughing fits that will actually produce blood when they start coughing this stuff up. And then they can get dysphagia as well. So supportive care for sure for our patients that are dealing with neoplasm in the lung. Let's continue their oxygen therapy, and let's make sure that we're maintaining the SATs and the end-tidal CO2 as best as possible for that comfort care. Let's make sure that this patient has a DNR in place, or some kind of living will, some kind of advance directive, I guess. Let's have that discussion with the patient. If that patient's alert enough, and they're still their own power of attorney, let's talk to them. Hey, sir, if something happens, or ma'am, if something happens during this transport, I understand that you have a DNR. Is that really your wishes? Family discussions. We need to talk about families, and unfortunately, some of these people that sign DNRs have multiple POAs. Well, we need to have all those POAs in order to be, all those POAs in agreement, in order to honor that DNR. So let's have that discussion with them. Hopefully they only have one POA that we have to deal with. And then, if appropriate, we can assist in their ventilations or intubate, depending on the DNR status or their advanced directives. Let's give them some IV access, and let's get these guys hydrated. Again, let's do some fluid challenges. Remember that because we do still have that neoplasm in the lung, it can act as if it is like fluid, right? So we can actually really back up fluids into the lungs for our patients by giving them too much fluid. So we want to just do real small fluid challenges and make sure that we're reassessing our lung sounds in between the fluid challenges. We could attempt bronchodilators, right? Really only bronchodilators. You're not really going to get too far with like a corticosteroid, because again, we're not really dealing with inflammation. We're dealing with a neoplasm. We're dealing with abnormal growth in the actual lung tissue itself. So if we're still hearing that wheezing and stuff, we're going to treat it just like we're going to do any other patient. Let's do the dual neb, okay? And then if they are in pain, there's nothing wrong with giving these people some pain medicines, depending on what you guys carry, right? Morphine or fentanyl, or you could probably, to be honest with you, maybe even try to get away with a very small dose of ketamine, depending if that's what you guys are carrying out there or not. But we do want small doses, and we want to make sure that we're pushing those doses very slow for our patients. And really all we're trying to do is not necessarily knock out the pain. We're just trying to keep that process of the respiration, of the ventilation drive, to where it's tolerable for the actual patient. Okay, guys, moving into RSV, still a lower airway, still considered a lower airway disease pattern, lower respiratory illness. Very common in the infants, children, and older people. Specifically here in New Mexico, we see this in mid-November to about March. It can live anywhere between half an hour to 30 hours on surfaces. So we want to make sure that if we do have kiddos, we're keeping our surfaces really clean, specifically around our house. Bleach does a very good job at killing RSV, but if we are able to get our hands on like a Virex or something like that, that's definitely way more beneficial than the bleach. Excuse me. We can have upper respiratory symptoms. It usually starts as like an upper respiratory infection symptom kind of thing. And then it will quickly progress to a lower respiratory infection. These people do need to go to the hospital. we're going to have to start giving them some fluids, and more than likely they're going to get some antibiotics as well. Okay, so management really is supportive, okay, based on how the patient is presenting, or how far they're actually in the actual disease process. We would love to give them some warm, humidified oxygen. You guys can do this with just some saline and the nebulizer. We need to get them some fluid replenishment, so let's start some IVs on these folks. And again, let's start doing that fluid challenges on them. Give them a little bit of fluid and make sure that we're checking those lung sounds to make sure we're not overloading their actual system with fluid. Bronchodilators could do very well for these patients, but really it's that racemic epi that can really do some good stuff for us. And it's that racemic epi. In most literature, they're saying 5 milligrams of 1 to 1,000 of epinephrine is actually nebulized. Most services, specifically out here in New Mexico, we actually do not carry true racemic epi, but you guys can just do regular epi in a nebulizer, 5 milligrams, 1 to 1,000, and nebulize that in as much as you can. Or as fast as you can for these patients, I guess is the best way to put it. Specifically with our kiddos, they do very well, very good response with racemic epinephrine. And we want to keep them calm, right? We want to make sure that they're in a position of comfort. Specifically, if we're dealing with a kiddo, let's take mom or dad with us so that they're at least comfortable, right? Stranger danger, stuff like that. But the kids do much better when it comes to RSV as far as treatment and progression of treatment than the older adults do on this one. Okay, when we're talking about tuberculosis, it is a bacterial infection. We already talked a little bit about this in our pneumonia lecture. And really our primary concern is respiratory TB. We need to put a mask on our patient, put a mask on ourselves, make sure we're using the appropriate mask for the situation. In 2011, New Mexico TB cases is right around 2% of our population. And I know this is some old data. I'm having a hard time finding newer data on this right now. But 2011 back in New Mexico TB cases, about 2% were reported of the population. 12% of that 2% of those cases actually died. It is very common among our Hispanic and Native American populations. And remember that we're famous for TB because when TB was going around rampantly back in the days, people would move out here because they like that dry climate in order to try to help combat the actual disease process. And about a third of the world population has known as latent TB. It's not actually active right at this time. Classic symptoms of tuberculosis is a persistent cough, night sweats, headaches, fevers, weight loss, and they could actually be coughing up blood as well. We have these signs and symptoms, guys. Make sure that you guys are taking care of yourselves first and protecting yourselves. You want to make sure that the patient gets a partial non-rebreather mask, right? Surgical mask for you guys. And then we definitely want to make sure that we are reporting our findings pretty quick to the receiving facility in order to get them prepared for the patient to be brought to their facility. All right, going into SARS, severe acute respiratory syndrome. This is a somewhat new disease for us. I believe it was back in, when was it? 2003 or maybe 2004, maybe sooner than that. I'm not quite sure. It is in the family of the coronavirus, and this is 100% droplet precautions. Okay. So make sure that you guys look back over what you guys need to do for droplet precautions, specifically masks, goggles, and a full gowning up. Okay. Really, it's presented like flu-like symptoms. That fever is usually greater than 100.4, so they basically automatically qualify for sepsis criteria. They'll have chills. They can have a non-productive cough, usually lasting anywhere between 2 to 7 days. And about 23% of the actual SARS cases that are presented with will actually require ICU admission. Treatments for SARS, please make sure that you guys are protecting yourself first and foremost. And the best way to do this is with the N95 mask. I would also throw on some goggles. And to be honest with you, I would also throw on a gown just to prevent those droplet precautions. The other thing is make sure that you guys are at a bare minimum, at least putting on a surgical mask on your patient as well. And this really, guys, when it comes down to good practice and to keep yourself safe, if you have a patient that's presenting with a cough, you guys should be at least at a minimum putting on a mask yourself and putting on a mask on your patient as well, just for good clinical practice, okay? We need to do some O2 therapy, okay? Making sure that we're trying to keep that end tidal within normal ranges and making sure that that SpO2 is within normal ranges. But remember, we're treating the patient, we're not treating numbers. So we want to make sure that we're trying to eliminate any kind of cyanosis or any other kind of things that might be coming on with the respiratory system itself, such as rate, depth, and effort of our patient. We really want to make sure that we're trying to provide the patient with enough oxygen needed in order to sustain respiration and perfusion. We want to do some IV fluids, okay? And again, specifically, if these people are starting to meet sepsis criteria, specifically with SARS, this can lead to a septic shock. So we want to make sure that we're reevaluating our patients frequently, specifically keeping an eye on lung sounds and blood pressure, and making sure that we're doing those fluid challenges, 200, 250 cc's, whatever really that Leslie is teaching you guys in class. It could be anywhere between 100 and 250 cc's, but really small kind of fluid boluses to maintain blood pressure, maintain hydration for the patient, and really just make sure that you guys are protecting yourselves when it comes to a SARS patient as well. Okay, so I included this slide on here just to kind of give you a breakdown between SARS and ARDS. ARDS stands for Acute Respiratory Distress Syndrome. The SARS component is the actual virus. It's the actual flu-like symptoms, right? And the problem with SARS is that people just believe they have these flu-like symptoms, and they don't go to the hospital after possibly a week of these symptoms. Well, after about a week and the severe coughing and the dehydration and your other typical flu-like symptoms with the high fever and stuff like that, that SARS can develop into a pneumonia. Once that SARS starts to develop into a pneumonia, the alveoli permeability, because of the fluid that's actually being trapped in the alveoli, preventing them from expanding and contracting for adequate respiration or gas exchange, it's actually going to start engorging those capillaries, and blood and other nasty material is going to start entering our lung tissue, right? So this is why you guys can get those kind of like pinkish colored sputum when these people go into their like coughing fits or something like that. And this is where the droplet precaution actually comes into play, okay? When we're talking about severe lung injury, or severe pulmonary edema, this can actually lead to what's called an acute lung injury, or what we call an OLLI, right? This can cause collapsing of the lungs. It can cause a pneumothorax. And then again, if we do get that pneumothorax and we get that hole in that lung, then that nasty stuff actually starts entering or third spacing into our system, and it just causes this spiraling effect where this can actually leads into a multi-organ failure, and this is how people actually pass away from SARS. So SARS is the start. It's the viral infection like the flu. That goes untreated because people just think that they got the flu, right? However, this flu lasts for anywhere between 7 to 10 days, and it's not getting any better. at which point they are going to continue to keep developing shortness of breath. They're going to have these really nasty productive coughs because now they have a pneumonia. And if that pneumonia goes untreated, just like any other pneumonia out there, it's going to start backing up into our lungs. It's going to start engorging the capillaries, and our capillaries are going to start spewing out the blood into our lungs and all that other nasty stuff for the acidity and whatnot into our system. Okay, guys, that's it. That's all I have for you guys for the lower respiratory infections. As always, if you guys have any questions, please feel free to contact me via email. And I will see you guys in our next class.